Good afternoon. Good afternoon. It's a wonderful Wednesday afternoon here in Delaware. Hello to those of you out here. My name is Dr. Scanterbury, and I am here to talk to you about kidney disease as it relates to, guess what? February is Heart Disease Month, where we talk about heart disease. We talk about how we can decrease our risk for heart disease for you who are on dialysis or for even if you have a kidney transplant. Now remember, for end-stage kidney disease due to dialysis or chronic dialysis, not for those on acute dialysis, heart disease is the number one killer. It's the leading cause of death for patients with end-stage kidney disease. So whether you are on dialysis or whether you've had a kidney transplant, it is still so important for you to take care of your heart. Understand that whatever your underlying disease is, and certainly for many patients, the number one cause of kidney disease is diabetes. Number two is high blood pressure. If you're African American, it's probably high blood pressure or hypertensive nephrotic syndrome. And so when you come to transplant, you're also going to have underlying cardiovascular issues. So the goal really is about taking care of your blood pressure. Both of these, diabetes and high blood pressure, are both silent diseases, except when they are extreme. Most people may be aware that blood sugar is falling, or they may be aware that the blood pressure is high, but that's not the majority of people. Most people are having just maybe some vague symptoms, but what causes cardiovascular disease? It's really about that high pressure or those diabetes causing injury or thickness or depositing what we call atherosclerosis, or thickening of the arteries over time from blood vessels working too hard, leading to problems with flow to your brain, to your heart, to your eyes, and to your lower extremities, and to your kidneys, which is why we end up with kidney disease, because those small vessels will become deteriorated over time. So it becomes very important to maintain good blood pressure, control your diabetes, and many of you, as you being diabetic, go to dialysis. Now remember, insulin doesn't get cleared because you don't have kidney function. So many patients will come off of your diabetic medication while you're on dialysis, or it may be to a very low dose because you no longer need as much insulin because it's not cleared, because it's usually cleared through the kidneys, but not cleared through the dialysis machine. So that's an issue. So it's important to also take care of your cholesterol. It's important to think about how you can, if you're smoking, can you decrease your risk of vascular disease from smoking? So try to get that smoking quit line to see how you can minimize your smoking and your risk of heart disease. So if you have any questions about how you can and what you can do, certainly exercise. We want you to exercise more, because what that does is it burns calories. Even if you're doing chair exercises, you don't have to always go out. You can walk around your house. You can walk in place. I usually tell patients, when you are sitting watching a show or watching the news or watching television, you may just want to get up and move in place, or do something in place during those commercials, so that you can keep your body active. So it becomes very important to monitor, talk to your doctor about ways you can improve your cardiovascular health. So hi everyone, hi Yolanda, hi Nancy, and so we're here to answer your questions. Well, first question is, what is the process of going from a catheter to a fistula or graft, and how long should a patient use a catheter? Well, most of the times, if you are diagnosed acutely with end-stage kidney disease and you didn't know it was coming, and you showed up in the hospital emergency room and you need to be dialyzed on an emergency basis or quickly, they will put a catheter in your big vein in your neck. Generally, they tunnel it under your clavicle into this vein, and so that's an access. That's a catheter that's placed for an acute situation or semi-acute situation where you need urgent dialysis, because both a fistula and a graft need to be planned and to be executed by a surgeon. So you have to see the surgeon and be assessed for what the status of your veins are. So you have to have good veins. They may need to do vein mapping to see whether your veins are big enough or appropriate to be able to have a fistula. And if not, they will place a graft. So generally, patients who are acutely diagnosed with kidney disease and need to be get those toxins out their body will have a catheter placed. Generally, that catheter should not stay in place for more than a few months, because the risk is infection. And two, the longer it stays in place, it will narrow the lumen of that vein. And so eventually that vein will become very narrowed, making it hard to get blood flow from your arm out. Patients would experience swelling of that arm, and it makes it hard for future events if you need to have another catheter, if you need to have surgery, and then your drainage from that side becomes affected. And unfortunately, for some people, it may clot or thrombose, which then limits blood flow from that arm, leading to venous stasis or trouble with swelling that doesn't resolve. So what, in terms of going from a fistula, once that catheter is placed for that acute situation and you've gone past the urgent dialysis, you should be referred to a surgeon who will then decide whether you have appropriate veins to place a fistula, and that fistula then connects your artery to your vein, allowing the vein to become very big, mature over time, and then that vein can be used as a source for arterialized blood to dialyze you. If for some reason in the process of doing a mapping you do not have good veins, or veins that they could elevate to the surface, then they will put an artificial graft, which is a synthetic material, between your vein and your artery, loop it in your arm, and then that's used for dialysis. So one of those two procedures will occur. You can also opt to decide that, well, maybe I don't want to go with hemodialysis. I want to go with peritoneal dialysis. And so you can also see the surgeon discuss that option of PD, where a catheter is then placed inside your abdomen. And that also needs to heal over time before you can switch over from not using the catheter anymore to whatever that permanent source of dialysis that you choose, whether it ends up being a fistula graft or peritoneal dialysis catheter. So that's very important to understand, that some people, depending on age and your risk of longevity, if you're older person, they may say, well, this person may not have any options for other dialysis, or they just do not want to have a fistula. Let's say they're in the 80s and they don't want to do any further intervention other than having this catheter, knowing that that in itself, if some people find it easier to keep the catheter because you're not being stuck. But remember, if you are a candidate for transplant and you have used up both sides by having catheters on both sides, it becomes very difficult to have that surgery, because now there's very little access to have a long-term line for anesthesia to place a catheter. So those can be limiting factors in an emergency. It can be limiting factors down the line, because you then have issues of blood returning to your heart, and you end up with varicosities because now this is obstructed. So that's a long answer, but the goal is you do not want to keep these catheters for very long, more than a few weeks to a few months, because they can cause significant complications as well as infections. So thank you for the question. Another question: is there such a thing as being number one, etc., on the list for transplant? There are patients who will get priority. Are you number one? There's really no such thing as number one, but you may be at the top competing with other people who may be number one or high priority on the list. So what happens is you have the points those that get priority first are pediatric patients, and those who get a perfect match. So if your 6 genetic markers are the same as the donor, 6 genetic markers, then you will pop up to the top, and maybe in that number 1 or 2, depending on how many other people on the list also have those same markers. So you may have someone who has the same genetic markers, and you may have, like here within your region area, you may have 3 different centers that may have 2 people each who all have those genetic markers that are the same as the donor. So then it boils down to waiting time and who has priority versus waiting time, antibody level. So the same people that you may be competing against may get eliminated by getting transplanted, and so you then fall into that category where you may not necessarily have a competition. If you had if you were a previous donor, you get priority. You gave your kidney to someone else, so you may be high up there in terms of getting extra time and points because you donated previously, and so you would be under all the kids and those who have priority. But other than being number 1 per se, you don't get on the list because number 1 depends on how well you compare to the donor's DNA. So you may be number 1 with a donor who is similar because you have more DNA matches compared to everybody else behind you, but there may be someone else in terms of number 1 because now somebody can jump the list because you're waiting for that kidney, but that kidney may go to someone who has more priority, such as a double organ, someone who's waiting for a kidney pancreas. So those things often, so it is not written in stone. So it's almost like having your own lottery numbers. Your lottery numbers are your DNA, genetic markers, and those never change. And what changes for every donor is the fact that each donor has different genetic makeup. And so you're shuffling those cards and based on time, and so you may be in the top 3, the top 2, the top 1, based on those people ahead of you being eliminated. But it's never consistent because each donor is going to shuffle those cards around because no 2 donors will have the same genetic makeup. But you may be higher up based on what you have compared to everybody else. So thank you very much for the question. Buttonhole, is this a type of cannulation site? And so, yes, it is. So some patients, it's a matter of when you are getting stuck, getting those needles placed consistently for dialysis all the time. Most people don't want that to occur to many different sites. So buttonhole is by choosing a particular area where is more easily to insert that needle because now you have a direct track into that fistula or that graft that you can then cannulate each time, and it's less painful. So for many people, they'll get some numbing medicine to place on the hand so that the needles are not that as painful putting them in. But when you have a buttonhole, it makes it easier. But like someone said, it may not do it as much because you may have more risk of bleeding because that's a direct communication, and it may not hold if you continually make that buttonhole larger by constant use. So the issue with buttonholes is that using the same place all the time, and you tend to get what we call aneurysms or dilated areas at that point, which becomes a problem down the line. And so then you have to have the fistula revised because now you're weakening that same area. So most vascular surgeons would say it's better to rotate your sites and use different sites than to use the same site constantly. Perfect match in transplant language. Are they really perfect matches? Well, yes, there are. You have 6 genetic markers, and you and a few more people, if you have a common blood type and certain markers are more common than others, then you may be, then you are more likely to have a perfect match. What we have done is change the terminology, such as we say zero mismatch, meaning that there are some donors where and some recipients where you are unable to type that particular genetic marker on your A, B, or DR genes, and so it may be what we call a blank. So if you have a blank, then you don't have a mismatch. Just imagine if you're playing dominoes. For those who have played dominoes, you have blanks. So if someone has a number and you have a blank, that's considered it's not a match, but it's not a mismatch. So you will more likely to have a mismatch, a zero mismatch, in that if you have 3 blanks, then you will come up more often because you only have to match 3 things because your other 3 are blank. So you will have a zero mismatch, many more chances than if you didn't have those blanks. So for some people, yes, we now go towards zero mismatching. So we know that because not everyone has 6 numbers in those slots. So we go with the opportunity of saying you don't have any mismatches, which allows many more patients to have the opportunity to get a kidney, not because they're matched, but because they're minimum mismatches. We have had some donors who may have only 4 points that are labeled, and a recipient that might only have 3 points that are labeled. So that very often those kind of things will happen. So the language is really about not mismatching, really than matching. Dialysis. We talked about heart disease and keeping your heart healthy. And one of the things we wanted to stress when it comes to the effects on your heart, especially when you are not making any urine, not making any significant urine, is that when you skip dialysis, or you feel like maybe I'm not feeling well, or I'm traveling, you are allowing those things to accumulate, those metabolites that are toxic to your system. But most importantly, you are stressing your heart, because now instead of that fluid weight being removed, it is now being stored. And so for another extra day, your heart has to stay ballooned with that extra weight of fluid if you gain significant amounts of pounds or kilos. So remember, 2.2 pounds is 1 kilo. So in kilos, we may not visually understand how much weight that is, but think about the fact that 5 pounds is about 2 kilos, 2.2. So you want to think about, well, can my heart handle that extra fluid? So now you've gained weight. If you've gone up in extra 5 pounds or 10 pounds, that's fluid weight that is now stretching your heart. So every time you skip dialysis, you're putting more strain on your heart. And the more strain you're in your heart is going to cause your heart to lose elasticity. So think of a balloon. When you blow it up and you let it out, and you blow it up and let it out, then suddenly when you let it out, it now does not have that ability to come back to its original shape, because now it's weakened and it doesn't have that elasticity. And so from time to time, for patients on the wait list, we will see that the longer they stay on dialysis, what we call your ejection fraction, or the ability of your heart to squeeze and pump blood out, goes down. So the amount of blood pumping out, maybe when you first get on the list, 65 or 70% of the blood is coming out, and then over 3 or 4 years, now it's down to 50%, and year 5, you're down to 40%, because now the heart isn't able to get as much blood out with one squeeze as it did before, because of those increased weight gain. And it also happens for people who gain a lot of fluid between dialysis treatments. So it's also important to make sure you keep your fluid gains down, because you're really putting a strain on your heart. And at some point, for us in transplant, we have to decide, is that heart ability strong enough for you to survive despite a transplant? Because I can give you a new kidney, but if your heart can't pump that blood appropriately, then that kidney is not going to see enough blood. So it becomes very important. Sometimes patients will get taken off the list because their heart function has deteriorated over time, or their valves have gone bad, and they're not able to squeeze effectively. So don't skip dialysis. If you're traveling, find a way to get dialyzed someplace. Plan your dialysis when you're going on trips, especially if you're on hemodialysis. We know that with PD, you can have your supplies sent ahead of time, and it's not as much a problem with those with peritoneal dialysis as it is with hemo, but you really want to continue to avoid skipping dialysis, and that's why doing dialysis more frequently is much more important. How long does a patient in remission from cancer have to wait to go on the transplant list? It all depends on the type of cancer. Some cancers may be incidental, and so you may not even have a waiting time. If you're on dialysis and for some reason we see, or you're coming to kidney transplant, and in that evaluation of your CT scan, we find that you have an abnormal finding on one of your kidneys, and it may be is small, and it may be diagnosed as a renal cell carcinoma. That after we took your kidney out because of that spot, then for some of those patients, because the kidneys were in disuse, and because the cancer is small, they may not have to wait. They can go on the list because they may need to wait anyway. But if you have a breast cancer and need to go through chemotherapy and receive treatment, then you have to wait until you finish your therapy. And oftentimes we work with the oncologist, hematologist, to decide what is a good period of time after treatment to know that you're cancer-free. So once they say you're cancer-free, for some people it may be 3 years, it may be 5 years, and during that time you may not be actively listed, but you can still be on the list gaining wait time, even though you're waiting for resolution of your cancer to go into remission. So it's important to know that you may still be listed inactively to gain time while you're being treated for your cancer, and also while you're waiting. So for many people, they may need to wait 5 years anyway in order for them to gain enough time to get enough points to get a transplant. So during that time, it works out to be good. If you have a more aggressive tumor, it may be that they may have to wait and see, do more studies to make sure you don't have metastases to different areas of your bone. But once you have been vetted by your oncologist and they send us a letter of clearance saying that it's okay to proceed with transplant, we list patients knowing that we also tell them about the risk of recurrence. So we do have to weigh the risk of the immunosuppression against the risk of recurrence of the cancer, as well as to monitor them appropriately after that. I have reduced my dialysis from 4 hours to 3.5 hours. How can I reduce it to 3? That you need to discuss with your care providers. It all depends on whether your fluid balance, what you need to get out for your diet. What is the reason, other than cleaning your system? Do you have weight gains? What's your potassium, calcium? All those things take time to effectively exchange balance and have that homeostatic balance with the dialysis fluid. So reducing your hours may not necessarily be a good thing unless you have some underlying clearance and you're not gaining fluid. So there's a lot of factors that go into that before you can say it's okay to reduce the 3 hours. So that is something you discuss with your dialysis providers, and monitoring your lab work and making sure that your heart and your fluid balance and that you're effectively cleansing your blood. You don't want to just say I'm doing 3 hours and come off with still having high uremia or not having the dialysis being effective, because then all you're doing is taking getting the top off the full glass, but you want to be able to get your kidney function down by dialysis effectively. So thank you very much for that question. We have about 5 minutes left. And another question was skin color changes. Why on dialysis? On dialysis, why? And so one of the things that's important to understand is phosphorus is in our diets. And when we eat phosphorus, we have to take those binders, those very big pills, to bind phosphorus within our GI tract so that we can excrete it, because it's not removed with the dialysis machine. So it's important to take your binders, but also at the same time limit your phosphorus intake. And so years of dialysis, you would often see patients get changed skin color because of phosphorus gets deposited in the skin. Not only is it gets deposited in the skin, it also gets deposited in your mixed with calcium inside your blood vessels. And so for patients, that discoloration of skin comes over time with hemodialysis. You don't see it as much or less so with people on peritoneal dialysis because the mechanism is a little bit different. So you want to make sure that you're taking your binders, you're keeping your phosphorus as low as possible by limiting those foods that are high in phosphorus, because you cannot fix it or change that with a dialysate fluid. So for patients who get this darkening of the skin and then get transplant, after transplant, we go to the other extreme where now the phosphorus drops because now you have a functioning kidney and we're trying to replace phosphorus. But one of the things we also see is that immediate change in skin color after transplant, because now you have a functioning kidney that's able to excrete phosphorus, and patients begin to notice that they feel differently, but they also look differently with the clearance of that phosphorus. So certainly pay attention to that. It may sound benign, but the effects of high phosphorus can be very devastating, not just on the skin, but also where it gets deposited on the inside. So thank you for that question. And let's see. Any more questions that I missed, please let me know. Perfect matches. Thank you for that information on buttonholes. I think, yes, most places are not doing them anymore. So I want you to keep in mind that as we come to a close, that this is a heart disease month, and we want you to stay healthy. So wherever you are, try to get your exercise in. Try to do some chair exercises. If you're on cholesterol medicine, please take your cholesterol medicine, because that's one of the things that limits patients' ability to get transplanted, is that oftentimes those blood vessels can get very hard and with deposits of calcium and cholesterol, which makes it impossible to implant the kidney. And that one of the issues with long-term diabetes is and cardiovascular disease is peripheral vascular disease. So if you have trouble with claudication or pain in your legs, make sure you get your blood flow checked to your legs. Make sure you see a vascular surgeon to see if there's anything that they can do about them to increase blood flow, especially for diabetics. So you want to monitor your cholesterol, monitor your phosphorus, limit your fluids so that you're not stressing your heart, control your blood pressure as much as possible, and do what you can to eat healthy and keep your blood sugar under control if you're post-transplant, because now you may need to be on insulin after transplant, because now your kidney is functioning and you're able to excrete insulin. So now you go from not needing insulin to needing it after, and those things can affect your kidney. So this was a great conversation. Thank you. Next time, come with some more questions so we can have a robust discussion on some other topics. But thank you very much for being here. Enjoy your day, and stay warm, stay blessed, get your vaccination, and stay healthy. Thank you so much.